All right. So, Bismillahirrahmanirrahim. Salatu wassalam ala ashrafil mursaleen. Thank you so much, Dr. Aiman, for the introduction. I'm very privileged to, and I'm very grateful for you and the organizing committee to invite me today to talk about the health informatics and neonatology. So my favorite topic, my favorite experience, and passed through and worked together in Time Hospital. This is a fascinating experience I ever had. So thank you. Today again, I'd like to go through some of the introductory session, I would say, exactly like you addressed, Dr. Aiman, for the health informatics in general and especially in neonatology. So by this, it's not easy to compile all together in 30 minutes talk. However, I made sure that in our agenda today, we need to explain what health informatics, identify reasons why to transform and use of electronic health records, and to clarify the importance of the quality data and explore some of the potential benefits of health informatics in neonatology. So health informatics is the integration of the health information technology along with the health information management. To this end, so health information technology makes the tool we use as professionals to handle the information using computers, hardware, software, networking, programming, etc. And the health information management, which is a big and huge department in healthcare organization nowadays. And it's meant to deal with records, coding, documentation, clinical documentation, etc. These kind of things. So health informatics is that integration and the application of technology tools and information systems in a healthcare setting or context. Another definition is the acquisition, storage, retrieval, and use of healthcare information to foster better collaboration among a patient's various healthcare providers. Health informatics plays a critical role in the push towards the healthcare reform. Health informatics is an evolving specialization that links information technology, communication, and healthcare to improve the quality and safety of our tiny angels and patient care in general. Another definition is the integration of the healthcare science, computer science, and information science, and cognitive science to assist in the management of healthcare information. This is by Aiman McCormack in 2015. So with subsets for medical informatics, nursing, pharmacy, etc., a couple of them in there. The definition I like is it's not that I like it's used by Professor William Hirsch. He's one of my professors in this field, and he's the head of medical informatics or biomedical informatics in the Oregon Health Science University. And his definition is biomedical and health informatics is the field concerned with the optimal use of information often by technology to improve individual health, healthcare, public health, biomedical research, etc. And hence the informatics applied in a more focused, as we mentioned, so it's medical, nursing, dental, etc. So we opted as professionals to seek structured data and through a digital healthcare environment. So using electronic health records, and I want please you to think from now on about think data in neonatal service. So data is the whole key. The key is data in whatever service. So think from now on only neonatal service and data. So question for you, and I need to have that answer probably at the end or at the discussion. So what's the best system to adopt? We need to have to implement electronic health records, and healthcare organizations across the globe, they range between paper-based environment towards fully electronic, and this needs another definition, what fully electronic means. And most or some of the healthcare organizations at the moment, they are in hybrid practice environment that's mixed of paper and electronic. Now, as mentioned earlier, the full electronic needs a definition. What does it mean? However, the question is still valid. What's the best system to adopt in any healthcare organization and setting? So keep that in mind as we proceed further. We need to have your understanding what that best system means. So with the painful experience we all had, those files and papers, and so one of the studies up to the information missing during patient visits. See the numbers and the percentage of lab results missing, letters, dictations, radiology results, etc. This is quite risky, and luckily we have experienced the transition from paper-based environment towards the electronic. Excuse me. So with paper files, again, the legible handwriting and the questions are still valid. With paper files, are they accessible, complete, quality of information? What sort of quality, any standardization? And here at this end, I'd like to thank Dr. Aiman, because during our working with the paper-based environment, he was very much pro the standardization of our approach and documentation, clinical documentation. So, and the paper files, are they useful information? Is whatever written there is useful or not? Are they retrievable? Are searchable? Available? What? So, of course, we know the answers that we challenge. This was a huge challenge. For here, we'd like to why to transform. We need to know why we need to transform. I was privileged to work on the healthcare transformation project in Nova Scotia in Canada. This is home, and we call that one person, one record. And I was assigned as the physician advisor, physician lead, to identify from a business perspective why we need to transform. And I had listed these 6 drivers why to transform. We call that targeted benefits. So the first was enhanced patient safety. So we need to think about our patients, and the first would be enhanced patient safety. Second, improve the quality and the clinical outcomes. So back to the safety point, 60% reduction was experienced with a couple, actually, not one, where healthcare organizations and contributed into 60% reduction in serious medication errors, because of the readily available evidence-based practice guidelines, readily available online, and alerts to alert practitioners for any point regarding, for example, ordering and maybe ordering medications, etc. So the second is the improvement of quality and clinical outcomes, and so it's improved compliance with accreditation in Canada standards called the ROPs, or required organizational practices, and preventable and respiratory events, management, and adverse events. The third driver is the improved patient experience and satisfaction because of the timely and faster decisions on patient care. This has participated in huge reduction in repeat testing and shortened turnaround time and wait time, and eventually shorter length of stay in hospital. Fourth driver was to improve the access to health information to providers. So having the information is readily available for the right clinician at the right time, regardless of location. The fifth driver is the health system use of information, and this is the whole thing today, is talking about this point, about the health system use of information, and in alignment with the Canadian Institute for Health Information Vision 2011. The sixth driver, and I meant to make it the sixth and last, is the optimized expenditure, because hospital information system is not meant to save money, however, is to optimize the expenditures and to redirect to improve health system. So this was meant to reflect the use of health information according to the Canadian Institute of Health Information, CIHI, Vision 2011. So primarily, the The health information, we provide the data as healthcare providers here at the bottom. So healthcare providers, we feed the systems with data, and these data primarily in use for the primary healthcare, primarily in healthcare and direct patient care. However, still the other use of the health information towards clinical program management, health system management, population health and research, etc. We need to keep that in mind, because now talking neonatology, clinical program management or service line management, again, we have a lot of data, and we'll explore this as we go further. Targeted benefits. So the targeted benefits, this has to be set first place before adopting a system, or even afterwards, though difficult little bit. So these would be at the organizational, facility, domain, service level. The stratified design, the benefits would lead to the discussion and agreement around related standardization, activities and efforts, along with definitions. So standardization is a way to standardize the approach, practice, and use of tools to yield comparable and usable data. And I need your thoughts here around customization and variability. So during the implementation of the hospital information system, a common question comes is, no, you know, at our facility, we need to customize the system to accommodate our needs, as we are special, different than the other facility within the same organization. We need to give this a big thought, because the more customization, the more availability, and think about data. This was I created to explore or make it to simplify the understanding of the integrated system, and so it's the patient-centric. So it's integrated, all needed modules in here, and this depends on the organization and the specialization, different facilities, what modules need to be implemented, etc. However, at the end, it's integrated health information system across the organization, and it's patient-centric. Now, think about if it's not integrated, and different modules, different vendors, and what would happen with the interoperability, which is a very big challenge for the quality of data and the integration and the flow of information between different modules. So this, of course, would be under the umbrella of privacy or HIPAA and accountability frameworks. So system users, you can imagine the amount of data generated each day, practicing and using a health information systems and different modules, different entries in back offices, in clinical settings. So healthcare is an information-intensive environment. You can imagine the amount of data generated every day. So with the patient journey and outpatient clinics and admissions, medical documentation, nursing documentation, machines generate a lot of data, lab, diagnostic imaging, pharmacy, etc. So all these data will get to the data repository, where the output would be report. So we need to be very careful. Now, have you heard about the DRIP syndrome? So DRIP syndrome is one of the syndromes we need to be very much aware of. It's data-rich, information-poor environment. Now, it's not a secret that it's not uncommon for healthcare organizations. They ended up having DRIP syndrome across the globe, and I came across many healthcare organizations where they implemented health and a hospital information system or health information system for 19 years or even more, and they couldn't make use of the rich data they have in their repository just lying in there of their use. So we need to be careful. That paradigm is very valid. So garbage in, garbage out, I'm sorry for that, but it's for a fact we need to be much aware of it. So a garbage data with the perfect model as informatics, along with the systems implemented, again, this yields garbage results. On the other way around, again, still with perfect data, so with all the standardization, all the committed users to follow the standardization, whatever, but with the bad or garbage model or system, again, garbage results. So we need to be very careful what we're doing in order to ensure the quality of data that's accurate, comparable, consistent, complete, retrieval, usable, reliable, updated, and relevant. So you need to be careful. Keep thinking about data quality every day, every time you enter data for whatever. I like this, the pyramid of data, information, knowledge, wisdom, because data is just reflects the individual facts, figures, signals, measurements, etc. This would yield to information that's more organized, structured, categorized, useful, condensed, and calculated. This yields again to knowledge, which is a more mature idea, learning, notion, concept, etc., and eventually to wisdom. The more we go up with the pyramid, the more maturation level within the organization to make use of the proper use of the health information system. So another question I need to have you to think about is transformation process is a vendor specific. This is very, very strategic. Is this vendor specific or vendor neutral? We need to keep these two questions: what's the best system, and is the transformation process is vendor specific? So healthcare and NICU. So a lot of efforts being invested now to work on machine learning techniques that have been used to develop models in hemodynamic care for newborn infants and ventilatory support, etc. So a lot of machines are available down there in NICU, syringe pumps, infusion pumps, monitors. So they will talk about this in a minute. But again, the machine learning techniques is the direction now, along with the big data and artificial intelligence in sort of predictability, disease prevention, surveillance, and screening programs, early identification, prevention, and early management, national health system management, and national international program management, and use of products in healthcare. So hemodynamic support in neonatal intensive care is directed at maintaining cardiovascular well-being, as we all know. So monitoring those vital signs plays an essential important role in augmenting care in a reactive manner. By applying machine learning techniques, a model can be trained to learn patterns in a time series data, allowing the detection of adverse outcomes before they become clinically apparent. This is very useful in NICU. So different machine learning techniques have been used to develop models in hemodynamic care for newborn babies. However, a lot of focus needs to be invested on their potential benefits and research, the pitfalls and challenges related to the implementation in a clinical care setting. Kaiser Permanente has capitalized on its integrated system and applied big data analytics. Eventually, it's a module, analytics module to improving healthcare outcomes. So analyzing years of maternal and neonatal data to develop an algorithm to predict the likelihood of sepsis in newborns, which has helped in reducing unnecessarily use of antibiotics. So Aiman was talking about yesterday's lecture about the use of antibiotics. So this would be reduced having algorithms and the big data analytics. So analyzing data from years of acute episodes to predict the likelihood of in-hospital deterioration, transfer to intensive care unit. These sort of analysis of data would lead to improving the outcome and improve bedside care. The translation bioinformatics approach are now biomedical knowledge, a new biomedical knowledge relevant to neonatal care. So incorporation of this new knowledge into clinical practice via integration within electronic health records would allow for prospective evaluation of its impact on patient outcomes and ultimately lead to the delivery of personalized precision medicine for that diagnostic, prognostic, and therapeutic strategies precisely tailored to each patient requirement. This is very important. So neonatal informatics was examined as it pertains to topics such as computerized provider order entries. CPOE is one of the modules we use for ordering, and the clinical decision support, again, the CBS module, and handover communication, data entry in whatsoever for clinical documentation, nursing documentation, machines data, generated data. So all of them would contribute to this topic. So the goal was to illustrate a realistic vision for the future of neonatal informatics by citing examples in which translational bioinformatics are transforming patient care. So translational bioinformatics is the transformation of increasingly voluminous biomedical data and genomic data into proactive, predictive, preventive, and participatory health. These concepts are very interesting and have some overlap. So talking proactive care, acting in advance, so it's just a proactive thing. So acting in advance to deal with an unexpected change or difficulty. Earlier recognition of the patient's deterioration status allows the intervention that may alter the clinical course toward an improved outcome, like in neonatal sepsis, for example. The other concept is the predictive care, that to state or to make something known in advance, especially using inference or special knowledge. So patterns mined from clinical data would be useful for predicting diagnosis and outcomes. For example, research examining patterns in the clinical data that precede a diagnosis of necrotizing pericarditis. This is very useful as well. Preventive care, so preventing, hindering, etc., for prevention. For the implication here is the prevention of preterm births. So early contributions resulting from translational bioinformatics approaches include the identification of candidate serum biomarkers for earlier diagnosis of preeclampsia and identification of maternal environmental factors that may influence preterm birth. The last is participatory care, that the process during which individual groups get involved with the decision making and the program activity. And the example here, the electronic tool can be used to engage parents of infants in NICU to improve family satisfaction and may facilitate early discharge from the hospital. So I think at this, I would just conclude. I'm very cognizant about the time. The take-home messages are: you need to ensure the proper use of electronic health records, and talking about the targeted benefits at the organizational facility and the service line, or the service, like neonatal service. And always remember data quality as providers and users for the electronic health records. Be aware of and sponsor the set and approved change within the organization, and be engaged and encourage others to do so. Follow standardization projects and whatever the targeted service, and many improvement potentials that are out there using health informatics in NICU. With that, I would conclude, and thank you so much.